Good evening, everyone, and welcome back once more to our monthly webinar series on critical care issues. Today, we are lucky to have with us Dr. Mariane Charron, an intensivist at Cooper, who has very kindly accepted our invitation to speak today and share with us her experience and her expertise. She will be speaking to us on nutrition in the ICU, which is a topic which everyone faces, and I'm sure we can learn a lot today from her. So thank you, Dr. Mariane, for joining us, and whenever you're ready, please, you take it away.
Thank you for having me. Can you hear me okay?
It's a slight echo. Yeah.
Echo. Let me see. Is this better?
Yes, a little better, yes.
Okay. All right. I'm not sure what you can see, but I will go ahead and start the slideshow. Is this okay?
Yes, we can see.
Perfect. All right. Well, thank you so much for having me. My name is Mariane Charron. I am actually from Montreal or Montreal in Quebec, Canada. So French is my first language. I did my critical care training at Cooper in Camden, New Jersey, and so this is where I work now. But I wanted you to have a visual of how far apart we are, but also that I work in a different area where I grew up. All right, and so today we're going to talk about the provision of nutrition therapy in the critically ill, routes of feeding, timing of feeding, tube feed formulations, tolerance, contraindications, and monitoring. Everything that we discuss is going to be based on a few guidelines from different from different societies. So the first one is the American Society for Parenteral and Enteral Nutrition, which were published in 2016. With a little update, a little 2-page addendum that they published in 2022. And then the European Society for Parenteral and Enteral Nutrition published their guidelines in 2023. So they're even more up to date. For those of you who are interested in critical care, nutrition specifically, this website, criticalcarenutrition.com, is curated by some members of the Canadian Critical Care Trials Group. And it's really an amazing website where they take every question that one could have about nutrition, and they do a meta-analysis of everything that's been published, and this is continuously updated. And so this is just one. I just wanted to show you all the things that you can look at on that website. If you ever have any specific questions, I highly recommend it. And so to start, I figured that we would use a theoretical patient, a 65-year-old man who comes to us with pneumonia complicated by septic shock and ARDS. He weighs 80 kilograms. So the first question one could ask is, well, should we provide nutrition therapy? And as you can imagine, it would be unethical to study whether, how long we can starve patients versus when to start feeding them. But thankfully, we do have at least an observational cohort study from 2012 that at least was able to show that optimal protein and energy therapy in mechanically ventilated critically ill patients, which they defined as reaching protein and energy targets was associated with a decrease in 28-day mortality by 50%, whereas only reaching energy targets was not associated with a reduction in mortality. So should we provide nutrition therapy for a patient? The answer is yes. Now, what route of feeding should we use? In a perfect world, all our patients would be able to eat orally, but that's rarely the case in the ICU, of course. So we're left with two options. On the left-hand side of the screen, we have parenteral nutrition, which essentially is intravenous feeding that bypasses all the usual process of eating and digestion. And that can be provided either through a central vein or through a peripheral vein. And then on the right-hand side of the screen, we have enteral nutrition. So that's liquid or at least very smooth supplemental nutrition that's given either through a nasal or oral access that terminates either in the stomach or the small bowel. But there can also be a surgical access placed in the stomach in the case of a gastrostomy, or in the small bowel in the case of a jejunostomy. And so this is what tube feeds look like. They have a characteristic white appearance, kind of like propofol or milk because of the fat content. And then this is what the commercial formulations will look like. And of course, there's blenderized food that can be provided for feeding. And so just again, what we were looking at on the prior screen, just focusing on the feeding routes either through the nose or the mouth on the left-hand side, and then just a few examples of the different types of tubes that can be placed. So the larger bore one on top, the Salem sump, that's routinely what we'll place through the mouth for enteral access. And the benefits of it is that it can be connected to suction if needed. So if for whatever reason we need to decompress the GI tract, it can be done with that tube. And we do preferentially use oral access as opposed to nasal in order to decrease the incidence of sinusitis. The smaller bore tubes, so the drop-off tube and the small bore feeding tube, are much more comfortable, and those do get placed through the nose, and they can be tolerated by patients who are not intubated. And these are just some examples of the surgical access tubes that can be used. So on both of these are gastrostomy tubes, but there's just different brands that can be used. All right, so coming back to our patients, so what route should we use? So this, as I was mentioning before, the Critical Care Nutrition website did a nice meta-analysis here, looking at all the studies that compared enteral versus parenteral nutrition. And if we look at the infectious complications that happen, we can see at the bottom of our forest plot there that the results favor enteral nutrition versus parenteral nutrition. And so that had been, I feel like when I was in medical school, almost 20 years ago now, I feel like that, you know, it was ingrained in us that that parenteral nutrition was really to be avoided at all costs, just because specifically of the infectious risk. And then when I finished my critical care training, this study was published in 2014 in the New England Journal of Medicine, where they looked at the trial of the route of early nutritional support in critically ill adults. And so their patients were randomized to be started either on enteral nutrition versus parenteral nutrition within 36 hours of admission and continued for 5 days, after which it went back to whatever the treatment team wanted. So what we found was that there were no significant differences in the mean number of treated infectious complications. So maybe what we thought, maybe what I had been taught wasn't accurate anymore. And they found no significant difference in 90-day mortality either. But if we pay attention to their study, it really has questionable generalizability, because all of the patients in this study had intact GI tracts. So none of them really had an indication to be on parenteral nutrition. And they only got the total parenteral nutrition for 5 days, which, and I apologize, I didn't actually ask whether any of you do work with parenteral nutrition, but generally when our patients end up on it, it's for longer than 5 days. If it's only going to be 5 days, like, it doesn't make sense to start it for such a brief period. And another interesting thing is that only 13% of those patients were malnourished, which is also low compared to what the majority of patients that get admitted. And so if we think about why the infectious risk is lower with enteral nutrition as opposed to parenteral nutrition, there's good data that comes from surgical literature that shows that the use of parenteral nutrition or the absence of enteral nutrition changes the gut-associated lymphoid tissue and affects mucosal immunity. Ultimately, that leads or promotes bacterial translocation from the gut. And so that's the main hypothesis about why not using enteral nutrition increases the infectious risk. And so again, enteral nutrition supports both functional and structural integrity of the enterocytes in the bowel. And so the most up-to-date answer that we have to this question about enteral versus parenteral nutrition comes from 2016, where this group did a systematic review and meta-analysis of all randomized control trials. And again, no effect on overall mortality, but enteral nutrition compared to parenteral nutrition was associated with a significant reduction in infectious complications. And one thing that's interesting that they were able to figure out was that in the group where patients received significantly more calories on parenteral nutrition versus enteral nutrition, that's where there was the most difference in incidence of infection. And so that's a good hypothesis generating statement. And so we'll see what future research shows us about that. So for our patient, what route of feeding should we use? I hope I've convinced you, it's enteral. Now, when should we start feeding? So if we look at again, as meta-analysis of early enteral nutrition versus delayed nutrient intake, there is a trend to favor, oops, sorry, I went too quickly, that favors early enteral nutrition for both mortality and for infectious complications. Now, different studies used a different definition of early, but ultimately Oh, sorry. I just wanted to see. I thought there was a question. I apologize. Okay. So different studies use a different definition of early. So that's how they ended up with within 24 to 48 hours of admission, to encompass all the different time ranges that different study used. All right, and the most up-to-date study that I found about this was published in 2023, where early enteral nutrition is associated with improved outcomes in critically ill, mechanically ventilated medical and surgical patients. And so, of course, because I guess they wanted to be different, their definition of early enteral nutrition was initiation within 3 days of mechanical ventilation rather than the 24 to 48 hours that everyone else had used. But essentially, the conclusions were the same. Lower hospital mortality, and then other benefits such as fewer mechanical ventilation days, shorter hospital and ICU length of stay, with ultimately a lower hospital cost. So when should we start feeding our patients? Within 48 hours of presentation. Now, what tube feed should we use? So normally when I give this talk to our trainees at Cooper, this is what I show them, our enteral nutrition formulary, where you can see there's a variety of different commercial feeds and all their nutritional content. And I had the pleasure of exchanging with Germana, who's in charge of nutrition therapy, and she was very helpful in explaining how tube feeds are managed at your hospital. And so she was telling me that most patients are fed with an enhanced kitchen prepared feed, and then there's a few factors that go into deciding. So the nutritional requirements of the patient, the financial situation of the family, and of course, food availability. Now, how do we determine energy and protein targets? So interestingly, both the American and the European guidelines say that the gold standard is to do indirect calorimetry with a metabolic cart, which, to be honest, I've never worked with that. I've never even seen one before. So it's just surprising that it's a gold standard, even though there's not a lot of good data to support its use. It's costly. It requires specific training. And then there's several limiting factors in that it cannot be used if your patient is on an FiO2 above 70%, or if the PEEP is above 12, or if there's an air leak present. You can't give nebulized medications while doing calorimetry, and then it has to be adjusted for renal replacement, mechanical circulatory support, etc. But I did want to mention that that's apparently what's recommended. So what we do use, and what has, some evidence to support its use, because it's the next best thing, is predictive equations. And so if we look on the left-hand side of the screen for energy requirements, if the BMI is less than 30, what's recommended is 25 to 30 kilocalories per kilogram of actual body weight per day. And then under that, I put the recommendations for higher BMIs. And then on the right-hand side of the screen, if we look at the recommendations for protein, If BMI is less than 30 or normal, the recommendation is 1.2 to 2 grams per kilogram of actual body weight per day. Now, how quickly should we reach our goals? The recommendation is to do so within 3 to 7 days. And the reason why you don't want to reach your goals too quickly is because of the risk or the danger of refeeding syndrome. So if we start at the if you start at the top of the screen there, if you have a patient if you start with a patient that is malnourished or already not eating prior to hospitalization, well, we know that already this patient is depleted in vitamins, protein, fat, minerals. And then when they come to the hospital and we start feeding them, their metabolism will switch from catabolism to anabolism, ultimately leading to the secretion of insulin. And if you remember, insulin will cause uptake in the cells of glucose, potassium, phos, and thiamine. And so if we do this too quickly, what can happen is just a severe depletion of electrolytes. So severe hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency. And ultimately, all of this can lead to congestive heart failure, severe weakness, cardiovascular collapse with lactic acidosis, and arrhythmia. So this can be a life-threatening effect of reaching our feeding goals too quickly. All right, so I don't know if this happens a lot to you, but we frequently get calls from our nurses about having issues with feeding, and so I always like to put this picture of a nurse calling to say something is going wrong with the feedings. And so for our patient, let's say that he's vomiting now, and so that leads us to talk about signs of feeding intolerance. So vomiting, of course, which is happening to our patient, but also abdominal distension, pain or discomfort, if your patient is able to communicate that with you, decreased passage of gas and stool, diarrhea as well. Those are all signs of intolerance. So is there anything that we can do to help improve feeding tolerance? So the recommendations are to do continuous feeding rather than bolus feeding, which I realize is not really an option when you're doing blenderized feeds, just in terms of, you know, the shelf life of the feeds that are being given, because the commercial tube feeds are stable at shelf life. So at shelf temperature. And so it's not like you have to keep them in the refrigerator or anything. Like they last long enough that we don't have to worry about them expiring. Otherwise, keeping the head of bed above 30 degrees. Going back to the continuous feeding, just so we're clear, there's also not good data about that. It's just thought that it makes sense, or it's simpler, and so that's what I've seen in North America being used. But again, we just need more data and better data about that. Other other ways to improve feeding tolerance. So like I was saying, the head of bed above 30 degrees, which regardless is recommended in all our ventilated patients to decrease the incidence of pneumonia. Post-pyloric feeding, which, you know, there's not necessarily a good way to do this. Most of the time it's by luck, where you just keep advancing your feeding tube and hope that it passes the pylorus and ends up in the small bowel. But that is one benefit of having your tube, the tip of your tube in the small bowel is improved feeding tolerance. And then prokinetic agents, which the recommendation is to try a course for 72 hours. Interestingly, the European Society for Nutrition recommends using erythromycin as a first-line agent, versus in the US they recommend metoclopramide first, and of course it's because of the incidence of antibiotic resistance. That's much more of an issue in the US. And yes, no problem. I'll share the slides for those who are asking. Now, are there any contraindications to enteral nutrition? I like this this figure from the European guidelines. So the part that I circled there, it lists situations in which we should delay or avoid enteral nutrition. And so if your patient is in shock and you're still increasing your pressor dose, and you haven't reached a situation where they're kind of stably unstable, then you should be vigilant and wait until the situation has stabilized. Otherwise, active upper GI bleeding, of course, we're not going to add feeding to the stomach in that situation. If there's overt bowel ischemia, obviously we won't be feeding. And if in the context of abdominal compartment syndrome as well, then you wouldn't want to be feeding at that time. And then I don't know if it's probably not part of your routine to check gastric aspirate volumes, because I'm not sure how it would make sense to check that if you're doing bolus feeds, which is what I understand is your practice. And besides, for the residual volumes, if it is being checked where you work, well, we have good evidence that says it actually doesn't change outcomes. And it doesn't make a difference in terms of the incidence of aspiration or pneumonia either. Okay. And so since we talked about situations in which we wouldn't want to do early enteral feeding, I wanted to point out this long list of situations in which it is okay to do early enteral feeding, and it should be done, because this comes up all the time. I feel like we're very good at finding reasons not to feed our patients, and so just going quickly from top to bottom there, if they're on ECMO, if they have brain injury, stroke, spinal cord injury, if they had GI surgery, if they have acute pancreatitis, if they're paralyzed, if they're prone, even if they have an open abdomen, as long as their GI tract is in continuity, then it's not a problem to feed them. Same thing for if if the patient has diarrhea, or even if the patient doesn't have bowel sounds, it's okay to feed them and monitor. So if we go back to our patient, what if he never tolerates enteral nutrition? So our nurse called us, told us that he was vomiting, and we did what we could to improve his feeding tolerance, but it doesn't seem to be working. So at what point should we start parenteral nutrition? So we got a good answer on this in 2011 in this trial that looked at early versus late parenteral nutrition in critically ill adults, where late initiation compared to early initiation decreased the incidence of infection, decreased the length of mechanical ventilation, and also was associated with a reduction in duration of renal replacement therapy. And so what they defined as late initiation for parenteral nutrition was after 7 to 8 days. And so that might seem like a lot if already on presentation, our patient was severely malnourished. And so when we talked about malnutrition and malnutrition scoring, these two screening tools that I put on this same slide there, the nutritional risk screening and the Nutrix score, are both helpful, but they're resource intensive in that they take time. You need labs, and so it's not necessarily easy to perform, and there's areas where they just don't have the resources to check all of these. But what has been validated is the mid-upper arm circumference, which you're probably used to seeing that in children, but it has also been validated in adults, where the mid-upper arm circumference less than 23 centimeters means severely malnourished, 23 to 25.4 is moderately malnourished, and more than 25.5 centimeters is adequately nourished. And so if you don't, if you don't have the resources to perform these more labor intensive screenings for malnutrition, then perhaps just your physical exam can be sufficient. And the benefit of this really is to identify whether this patient needs early parenteral nutrition, for instance, or is someone that we really need to try to reach our goal calorie and protein requirements sooner. And so I also wanted to talk about monitoring of medical nutrition. And so over on the left-hand side, glucose and insulin. So especially after you start feeding, so whether it's enterally or parenterally, you have to watch for hyperglycemia. And so the recommendation is to check a glucose at least every 4 hours for the first 2 days in general. That said, since our patients rarely die from hyperglycemia as opposed to hypoglycemia, like I think it's reasonable to not check every 4 hours if that's not an option. In terms of electrolytes, potassium, magnesium, and phosphate should be checked at least once a day for the first week. And then remember, if it starts looking like the patient is developing evidence of refeeding physiology. So if their phosphorus is decreasing, then we really need to increase the frequency of our checks to 2 to 3 times a day to avoid refeeding syndrome. And so I think I spoke faster than I was thinking, but I like this bundle statement from the American Society of Parenteral and Enteral Nutrition, because I find that it's a good summary. But so their bundle statements are to first assess your patient on admission for nutrition risk and calculate both their energy and protein requirements to determine their goals. Next, initiate enteral nutrition within 24 to 48 hours following the onset of critical illness and admission to the ICU, and increase goals over the first week. 2 goals over the first week of their ICU stay. Next, take steps to reduce the risk of aspiration and improve tolerance to gastric feeding. So whether that's using a prokinetic agent, using post-pyloric feeding, elevating the head of bed, etc. And then it's important to implement feeding protocols wherever it is that you're working. So essentially, whatever it is that you do, just make sure that someone is paying attention to nutrition and that this happens in a systematic way for every patient. I'm going to skip the part about the gastric residual volumes because, again, this doesn't really apply for when you do bolus feeding. But if you do end up somewhere where it's part of their can volume before having to pause feeding. And then if your patient is severely malnourished from the start, or if they're unable to tolerate enteral nutrition, then start parenteral nutrition early. What's recommended is that if your patient is unable to tolerate 70% of their goal energy and protein requirements, that's when you would consider using parenteral nutrition. And I thought that this quote from an article from the British Medical Journal was a good summary in that they identified the paucity of evidence relating to nutrition practices for critically ill patients, especially in resource-limited environments. And so their conclusion was that there's urgent need for further research to explore low-cost, highly sustainable enteral nutrition solutions to prevent complications from critical illness. And that's what I have for now. Late initiate. Okay, let me look at the questions. Okay. Please share notes. Yes, my pleasure. I will. Does late initiation mean that you identify an indication for TPN, but then continue enteral for 7 to 8 days? So late initiation would actually be if you are able to provide some enteral nutrition, that you would do so. And if your patient doesn't meet 70% of their goals within those first 7 to 8 days, then you proceed with parenteral nutrition. if they're not able, like if they have a contraindication to receiving enteral nutrition, then assuming that they're not severely malnourished on admission, then you could wait for 7 to 8 days before starting TPN. Otherwise, if they are already malnourished when they come in, then you can make an argument for starting TPN before waiting a week. Guidelines of parenteral nutrition in CKD patients stage 4 or 5 who are enteral nutrition intolerant. I wonder if the question is about perhaps like volume and electrolytes, but that would need to be adjusted, of course, based on renal function. So depending on so if they're stage 4, I'm guessing they're still making urine, and so you should be able to still provide some degree of electrolytes through your parenteral nutrition, as opposed to if they're already on dialysis or they're anuric, then you have to be even more cautious both about the electrolytes and the fluid content of your TPN. Let me see if there's another question.
Yeah, thank you, Dr. Mariane. I think those were the 2 questions on the chat. Yeah.
Okay.
If I may ask you one, so there was a point when you spoke about trying to improve tolerance of nutrition in patients, enteral nutrition.
Yeah.
So those recommendations, would you suggest to start from the beginning, or would you wait for someone to get intolerant and then start one of those? Like I know elevating head of the bed, yes, we do it normally, but what about the other options?
Yeah, I think like 5 years ago, even I used to think that we needed to be really aggressive and really try to meet our goals quickly. But I feel like now there's more data showing us that like it's okay to wait, that you really want to avoid overfeeding and refeeding. And so now I feel more comfortable if I'm not able to meet the goals like within 2 to 3 days. And so now I tolerated up to trying to get to your goal within the first week. So somewhere there in the middle, if your patient is struggling, I think that's where I would start exploring the other options. Do you have access to the erythromycin and the metoclopramide?
Yes, we do have erythromycin.
Oh, great. Okay. Yeah, I wasn't sure if that was an option. Then yeah, it's very easy to just start it and then perhaps start looking into whether you can get post-caloric access.
There's another question on the chat that says that in settings where locally prepared food like porridge and cow's milk is used, how best can we estimate the protein content and energy?
Right. So Germana was telling me that she basically has a list of different foods and what their caloric content is. And I kind of did the same thing myself in preparing for this. I just kind of I just Googled to see. Now, of course, it's not not the most accurate thing, but it is a good estimate. It's a good place to start.
Right. There's one more.
Difference in the type of feed provided for post-caloric feeding in terms of energy and protein requirements. No, it's the same thing. no difference that we're bypassing the stomach.
Perfect. Thank you. Anyone has any more questions? Yeah, go ahead. Yeah, we have one more in the chat. What are the ethical considerations for providing nutrition in critical ill patients?
Yeah. So this is something that that comes up not infrequently. I think when I discuss end of life and goals of care with families, it's one of the things that I do remind families of is that at the end of life, in the dying process, patients generally do not feel hungry, and so it's not as uncomfortable as we might imagine, as you know, as a healthy person who's not eating. You know, that sounds terrible for us, but that's probably not the case for their loved one. And so not only are they probably not feeling hungry, but also trying to force feeding on them might actually make them feel worse, because as we know, at the end of life, there's just more GI symptoms and GI complications, and so as part of the whole conversation, you know, if we're talking about removing the breathing tube and stopping pressors and all that, then to me I feel like it just comes as a bundle, that, you know, we also stop tube feeds in order to avoid just prolonging the dying process. I don't know if that answers the question, because I know there's also some families will ask for just fluids and not food, and that's also kind of part of that discussion of saying, well, they're probably not really thirsty, they're probably not uncomfortable, and so it would be okay to hold off. But those are always tricky conversations to have. A delay in recovery when using local foods instead of I'm pretty sure that this has never been looked at, and so the commercial formulations came around like in the 70s, I believe, and that's because it was just easier or simpler, or that's what people thought. But my understanding, and this is just kind of from reading, you know, not certainly not randomized control trials, but just from reading family reports and such, is it seems like using local foods is actually better tolerated for patients. It sounds like they have less diarrhea, less stomach GI upset in general. And I think it's actually really, I've never had the pleasure of working somewhere where we did blenderized foods, but I would be, I think it would be fascinating to officially look at that and see, because something tells me it just makes more sense than the commercial stuff. But I could be wrong. When is the right time to consider gastrostomy tube and not nasogastric feeding? So I guess depending on, obviously on a case-by-case basis, if it looks like your patient is not going to be able to swallow and thus not need enteral feeding, and then depending on, I guess, their comfort as well. So There's some patients that seem to tolerate the small bore feeding tube just fine, and they're not pulling at it, and it doesn't seem to bother them. Then that's reasonable to continue that. I find that in the US, the rate limiting step is where the patient is going once they leave the ICU, because here they have these long-term acute care facilities or acute care hospitals. And so a lot of these facilities will actually require that the patient have something more permanent like a gastrostomy, which is not necessarily in the patient's benefit, especially if the patient is quite malnourished, and we know they'll have difficulty healing at the site. And so that hasn't actually been looked at. I feel like the reason it happens systematically in the US is really because they're trying to push people to more chronic care facilities. In your experience, which one do you think is more beneficial? The food prepared at home for tube feeding, or the commercially prepared one during the recovery phase? That again, that hasn't been studied, unfortunately. And I can see how it might be difficult to get funding for such a study, because obviously there's no there's no financial incentive for anyone to prove that the commercial feed is not as good as the home prepared stuff. But it certainly pleases my, when I think about it, it certainly pleases my mind to think that that someone would be giving me something that contains real food and that they prepared themselves. But maybe I'm being too optimistic there. Oh, glutamine containing supplements. So we have to be careful there. So high dose glutamine was looked at in the Redox trial, REDOXS, and it was shown to actually worsen outcomes and increase mortality in patients with multi-organ failure. And so at that point, for medical patients, glutamine just kind of was officially not recommended. The only situation in which there's some data to support the use of glutamine supplementation is in burn injuries. And even that, within the last year, there's another study that came out showing that perhaps glutamine doesn't change anything in burns, but at least it didn't worsen outcomes the way that it did for the general medical population. The recommendation for frequency of feeding. So like I was saying, both the American and the European Society, they both say, rather, they both recommend using continuous feeds because presumably it's better tolerated. But to be honest, that comes from like expert opinion. That hasn't actually been studied. But it's certainly, I think it's a good future study to do, to see how it affects, you know, our just our hormonal cycles and insulin release and all that. But yeah, we just need someone to do the work and study that. Is it possible to add protein powder and local foods prepared at home to top up the amount of protein? Yep, absolutely. And that's the same thing. That's the same thing that we do over here. Like not that the name matters, but there's there's just like a commercial protein powder that we add to the tube feeds to make sure that the requirements are met. Initiating enteral nutrition within 24 to 48 hours or 3 days of admission. I'm assuming this means admission to ICU. Yes, that's correct. Patients that are not yet in the ICU but are feeding poorly. The studies or the studies that were looked at to make the recommendation of starting within 24 to 48 hours also looked at some non-ICU patients. And so I think that the recommendation can extend to them in the sense that early on we can make our assessment to identify whether this patient is at high nutrition or high malnutrition risk, and if they are, then start identifying whether they are meeting their goals for energy and protein, or at least 70% of those goals, and if they're not, just orally, then you could start enteral nutrition. But I guess you would just need to be able to monitor or have, yeah, just have an assessment to see how much they are eating. The raw eggs be of any importance to boost the protein requirement? I have to admit, I am not sure. What I would wonder about for the raw eggs is depending on the state of the patient, is if the egg has been pasteurized, just in terms of their risk of bacterial infection. But I would need to specifically ask Germana to see whether this is something that that is recommended on her list that she used to make the blenderized feeds. But I also wonder, in terms of a raw egg, now granted, I imagine it's mixed with other things, but I would wonder about the consistency and how it might end up blocking the tube, especially if we're using a smaller bore tube.
Yep. Thank you, Doctor. Thank you, everyone, for those questions. Very, very lively discussion. I wish we could go on, but yes. So we have reached the end of our time, and thank you, Dr. Charron, once more. And maybe we could have a follow-up session for this topic. Sure. There's a lot of questions on this as well.
Yeah, thanks for all the questions, everyone. This was fun.
So I hope to see you all again in the next seminar. Next webinar. We have a lot of interesting topics coming up. And Dr. Charron, thank you very much again for your time, for sharing your experience, your expertise with us. I'm sure I echo the comments on the chat that it was an amazing presentation, very informative, very practical for us to take back to our practice. So with that,
and I'll send you the slides.
Yes, and I will share it with the participants as well. So thank you all, everyone, and have a great day.
Bye. Thanks, everyone.